On pause. So I want to welcome everyone to the What the F Research Forum on fibroids, and this month celebrating endometriosis Awareness Month. I got to get it right if we're going to talk about it. And I am pleased on behalf of the research committee and my co-chair, Dr. Rochelle Wolf, to welcome you to this discussion. So if you're watching on YouTube, hi. So what we're going to do today, just to give you a sense as to what's happening, we are going to give you a brief sort of overview of the latest research, a patient perspective, and a physician perspective to kind of help you, guide you in kind of making any decisions that you might be making based on what brought you to the session today. And then we're going to open it to stories. So we will be recording the first portion of the session with the overview. When you're sharing, we want you to feel totally comfortable. So we're actually going to not record you, but we may record the answers of some of our panelists. All right, does that sound good, Yvette, Jaleese, I think, and Meg? Yes, I got a thumbs up from Meg. I'm going to go with that. All right, so I'm going to just, as a quick overview, just to, this is our little commercial. I'm going to share. And please feel free to put anything in the chat. If you have any questions during the course of the event, we want this to be really informal and to just flow. And hold on, now I'm going to multitask now that I've got a couple more people in the waiting room, so let me just let them in. Yes, yes, yes. All right, and so we are, as I mentioned, the research committee for the White Dress Project. We did our first survey last year, and we are now conducting these virtual series to really kind of bring research to the masses, if you will, and translate that research from sort of scientific to what does that mean for us as folks that are dealing with some of the things that we're talking about. So as I mentioned, Dr. Wolf and I are the co-chairs, and this in honor of Endometriosis Awareness Month, we are asking the question, are fibroids connected to endometriosis? And we don't mean physically, so we'll talk more about that. So just as a quick, we'll do a little, you have been welcomed, and we'll do some other introductions of our guests, and then we'll actually talk a little bit about the topic. And then, of course, we think one of the most important things is to hear from you. So what does this mean for you? What do you want to share? You might have information based on what you've experienced that would be helpful to someone else on the call or in the audience that will watch this in the future. So my name is Tanya Leek. As I mentioned, I'm the co-chair. I'm also a health and wellness coach. So I actually do fibroid coaching as part of my health and wellness coaching part of my business. And I am just really, really blessed to be working with the incomparable Dr. Rochelle Wolf, and I will let her take it away, introduce herself and our guests.
So I'm Dr. Rochelle Wolf. I am also the co-chair of research for the White Dress Project with Tanya. I am an interventional radiologist who's been practicing, and I hate to admit, for about 17 years now. I have throughout my career kind of had a special interest in women's health. And I think it's important because, at least within my field, only about 8 to 10% of all interventional radiologists across the country are female. Not that you need a female doctor, but like I said, throughout my career, I've just had a very specific interest in women's health. And so that led me to the White Dress Project. And I'm in private practice, but it doesn't mean you can't be interested in research. And then I'd like to go on and introduce our special guests tonight. First, we have Dr. Chantel Jiggets. She is actually a board certified OB/GYN who obtained additional training to manage complex gynecologic disorders using minimally invasive techniques, which I think is really, really important for women to be aware of. She offers expertise in medical and surgical treatment of pelvic pain, endometriosis, abnormal uterine bleeding, uterine fibroids, masses outside of the uterus, kind of by the ovaries, and something called adenomyosis, which we'll talk a little bit more about. She performs a variety of robotic, laparoscopic and hysteroscopic procedures, which is fabulous. She currently practices at Baylor University Medical Center, which is part of the Baylor Scott and White Health in Texas. In her free time, which I think is always important to know about, she enjoys reading, yay, hiking, nail art and design, and spending time with family and friends. And then we have Michelle Ng, who we're very, very fortunate to have join us today. She is a mission-driven product designer based in New York with over 16 years of experience in the tech industry, and I'll let her talk about that a little bit later. As someone who has both endometriosis and fibroids, she is on this incredible mission to help girls and women understand the symptoms and treatment options via her company, New Moon Health, which has both a website and app, which is very, very, very exciting.
Yes, yes. And I met Dr. Jiggets at the Dallas Patient Empowerment Brunch. So I encourage you all you will meet fabulous people if you go to the brunches, and you can check our website for the one upcoming. And I met Michelle randomly through LinkedIn and was so excited to connect paths with her, to cross paths with her. And I think we've got a lot of good things coming. So everybody, yay, happy Endometriosis Awareness Month. You are officially celebrating by becoming more aware with us with What the F. So please remember, put any questions that you might have in the chat and we can get to them either as we go or when we enter the question and answer portion, the sharing portion. But what we want to do with introducing the topic of how are they connected is really, okay, let's set the table with what it is, and then talk about some of the connections between the two. And then Michelle will share her story and kind of any of the thoughts that she has about her lessons learned and what happens when you have both fibroids and endometriosis. And then Dr. Jiggets will dig in a little deeper in, okay, so now what, right? Now that you know all of this new stuff, you've learned all this new stuff, what do you do with it? All right, Dr. Wolf.
I always have to remember to unmute myself. So if anyone's seen any of our previous What the Fs, Tanya has come up with an acronym of TOTM. And I was like, what is that? And that stands for the term of the month. And so in celebration of the term of the month for endometriosis awareness, our word for the month is endometriosis. And so what is endometriosis? And the definition, according to the Mayo Clinic, is defined when the endometrial tissue, which is like the tissue that lines the uterus called the endometrium, grows outside of the uterus. It can kind of grow anywhere, but most commonly it involves the ovaries or the tubes that connect the ovaries to the uterus called the fallopian tubes. It can also involve other organs and lining of basically your pelvis and abdomen, and rarely elsewhere in the body. The interesting thing is, this tissue can still go under the same hormonal control as it does when it's inside the uterus. And unlike when it's inside the uterus, it's not connected to the outside. You can't actually shed or pass that during a normal menstrual cycle. We'll talk a little bit later, and I think Dr. Jiggets will inform us a lot. It's notoriously hard to diagnose endometriosis. It's very, very difficult. And then a related condition is something called adenomyosis. And this is so-called like internal endometriosis, or what I like to tell people, it's kind of like endometriosis of the uterus. And that's actually where that lining grows into the muscular wall of the uterus. And clinically, sometimes, at least in my practice, it can get confused actually with uterine fibroids, because it can sometimes make the uterus enlarged, or even in a focal area, something called an adenomyoma, like can sometimes be confused with endometriosis or uterine fibroids, and sometimes MRI is very helpful in making that diagnosis.
Now I have to remember to unmute and now go back. So how is endometriosis connected to fibroids? So this is a bit of the research, and some of it is observational. Well, most of it actually, we're going to talk a little bit about kind of how research is happening and how it's evolving in this area. As you all know, women's health is not necessarily the most prioritized. We're not as heavily participating in the research, sometimes because we're not recruited, and sometimes because they're just not researching conditions that affect us either primarily or uniquely. So what we do know is that uterine fibroids and endometriosis are two of the leading causes of uterine disease among reproductive aged women. So it does occur basically starting in puberty. You can have either one of these conditions all the way through the end of your reproductive age. Endometriosis and fibroids are estrogen dependent. So, you've probably heard a lot about estrogen and its effects on our body. And so we'll talk a lot about this in terms of kind of how our bodies work with estrogen really can affect our risk of endometriosis and fibroids. And as I mentioned, occurs during the reproductive age. So recent evidence suggests that there are potentially common genetic foundations for these two conditions. So that's continuing ongoing research, and we're actually partnering with a genomic artificial intelligence company to do some additional research in terms of sort of some of these genetic foundations that may lead to an increased risk for some of these conditions. Another thing we wanted to mention that has been in the research is that there is an increased risk for both endometriosis and fibroids linked to ACEs, which are adverse childhood experiences. So, one of the things that, we found in our survey and is that stress, it can lead to some of these, conditions. Now, stress is very difficult to measure. So when you talk about research around the link between stress but you can measure adverse childhood experiences, traumas that happen early on, and they have shown that there is an increased risk for both fibroids and endometriosis linked to that. So in terms of how many times fibroids and endometriosis coexist, so Michelle is either a unicorn or not, because it's so the retrospective studies that look sort of back at people that have had either hysterectomies or some sort of laparoscopic or hysteroscopic procedure has shown that the likelihood of finding that is between 12 and 86%, which is a huge variation. So it's unclear, and Rochelle talked about this earlier, is that it's very difficult to diagnose. And I know Michelle will mention some things about that. So I think that's part of the reason why, and for those of you who know research, right, you've got studies that have 20 people and 86% is a low number, but if you have 12,000 people, you get probably a more accurate number, and it's probably going to be lower. So that's part of the challenge with looking at some of these reviews of the studies done to date. This graphic shows that there are definite symptoms that overlap, which Rochelle will talk about shortly, between endometriosis and uterine fibroids, and how that may cause some confusion for diagnosis. But we found this in the research as well, is that the annual estimated economic cost, and I didn't write this, Dr. Wolf, was this global or was this national? This is a global number, right? It's national?
This is in the US.
This is a US number. Okay.
Yes.
I didn't want to, because I thought this would have, but I was like, I don't want to say that, because these are big numbers, right? And we're talking about lost productivity, as well as healthcare costs. So there's direct costs related to the healthcare, but then also indirect costs related to what happens when women are knocked out. This is my little aside, a friend of mine who says when he gets sick, he's sick. When his wife gets sick, the household shuts down. So that I think speaks to not only the economic cost, but, and for those of you who have been, subject to pelvic pain and some of those common symptoms of both fibroids and endometriosis, you know how that has affected your life. So that's something to think about. So let's talk a little bit about those symptoms.
So when we look at uterine fibroids and endometriosis, there are a lot of symptoms that overlap: pelvic pain, painful periods, impaired fertility or infertility, fatigue, pain with intercourse, which is one of our terms of the month last month, bladder and bowel dysfunction, and pregnancy complications. Tanya kind of alluded to, the causes of both conditions still are not well understood, but there's probably more research and a little bit more understanding in the realm of uterine fibroids compared to endometriosis. And again, this is likely due to the difficulty often in diagnosing, endometriosis. So I'm going to put my radiology hat on. And so when we look at diagnosing both conditions, uterine fibroids, when it comes to imaging, it can more readily be detected on, just a routine screening ultrasound or, an MRI. Whereas when we look at endometriosis, especially in the early stages, it can be notoriously difficult to see on any of our imaging studies, and often requires, a surgical procedure to make the diagnosis, something called laparoscopy, where they're looking in the abdomen, or even an open surgical procedure, laparotomy, which is less common, but sometimes that's how it gets diagnosed. And this partially can contribute to that large number that you saw Tanya show on the cost to the healthcare system. In addition, both conditions have a wide range of symptoms, but even in some women who have it, they can be asymptomatic with either condition. But endometriosis, when you kind of look at that diagram previously, severe pain tends to be a more predominant symptom of that, versus when we look at fibroids, one of the more common things, and even in our survey, is anemia and heavy bleeding. When we look, on the time of diagnosis, like particularly for endometriosis, here in the US, this is according to Yale, that women will suffer with endometriosis on average 10 years before obtaining a proper diagnosis. And both of these entities can actually cause impaired fertility or infertility, but the research has shown that endometriosis actually can be seen in up to 50% of women with infertility. Fibroids, on the other hand, if you kind of look at the numbers that are out there, and Dr. Jacobs can probably correct me if I'm wrong, but about 5 to 10% of infertile patients are found to have fibroids, and even much less percent, somewhere around the 1 to 3% range, is where fibroids are actually the sole cause of infertility. So I think, in regards to kind of the pain and the fibroids, I think it would be helpful, Dr. Jacobs, if you kind of want to talk about, the differences in the types of pain from fibroids versus endometriosis. Can you kind of help decipher what one woman might have versus the other? And then specifically, kind of how can endometriosis or fibroids kind of impair that fertility, particularly endometriosis, because it's such a big component. So I'll let you talk a little bit.
Yeah, so definitely. I mean, that was great. Just kind of overview of all the symptoms, and trying to kind of separate the endometriosis from the fibroid. So, in general, pelvic pain is such a broad topic. There's definitely GYN or gynecologic reasons you could have pelvic pain, but there can even be some whole body systemic, syndromes that can give you specific pelvic pain, things like fibromyalgia. There can be trauma to the pelvis. So that's kind of a catch-all term. So when we're thinking about fibroids versus endometriosis, this idea of cyclic pain versus cyclic pain becomes a little bit important. So, just a patient being able to say, do you have the pain with your period in a predictable fashion, even if it's a few days before your period or after? Sometimes that could be, more of a fibroid picture. But endometriosis is a progressive syndrome. So a lot of times endometriosis can just start as painful periods. And a lot of, of my patients, they just tell me, they were told that they have painful periods. It's just, just a normal part of their experience, with their periods. But over time, what you see is that the pain can become non-cyclic. So it's almost like a positive feedback mechanism where the body is just kind of ramping up with pain. So now you're starting to have sporadic pain. You may have exacerbation of that pain with your period as well. So both of those kind of overlap somewhat. With fibroids, definitely some of the symptoms are going to depend on where in the uterus your fibroids are. So if they're, in the lining in the middle of the uterus or in the endometrium, that usually gives people issues with bleeding too, and maybe some pain as well, and also can impact fertility. Then once we get to, fibroids that are in the middle of the muscle, if they're very large, absolutely that can cause a lot of pain, usually also cause significant bleeding. That can also cause some issues, maybe not with getting pregnant, but maybe some complications during pregnancy. So you start to be concerned if the placenta is attaching to the fibroid, when it comes to deliver, that may be a difficult, placenta to detach. And that comes with, sometimes increased bleeding. It can, lead to preterm contractions, which, some studies show that can, may or may not lead to preterm delivery. Sometimes if these fibroids are really big and they're blocking, access to the pelvis for the fetus, for the baby, these women can end up with an increased risk of cesarean section too. So that increases kind of some of the morbidity or injury that you can have with delivery. The other issue with fibroids is sometimes they're very big and they're kind of hanging off the back of the uterus, right? So here you can have pressure symptoms, pressure on the bowel, you have constipation, maybe you have a feeling that you always have to have a bowel movement, even though nothing is coming out, pressure on the bladder, you feel like you always have to urinate, nothing is really, you don't have a full bladder, but you feel the urge to go. Endometriosis is such a wild card. It really can give you so many different symptoms, whether it's pain with bowel movements, even blood in the bowel movements, pain with urinating, blood in the in the urine as well. Sometimes those symptoms happen during your period. So, endometriosis definitely can give you really just a gamut of things, and both can impact fertility. So endometriosis, definitely, it can cause a lot of scarring in the pelvis. So if your fallopian tubes are not open, they're kind of scarred down. You can't get pregnant if your uterus is not connected to, that ovary, basically, right? If the egg cannot, transport through that fallopian tube. And the other thing is that, something with endometriosis, what we're seeing in studies is there's a lot of different changes that's going on at the level of the lining of the uterus, not well understood. But, even if you have an endometriotic cyst on the ovary or deep lesions in your pelvis, that if you remove those things, it increases fertility. So it's not well understood, but there's something about the environment in the endometrium that's causing infertility for some women. So
I think too, I read somewhere that, one of the mechanisms too related to infertility with endometriosis, because I was always wondering about that, but it's like an immune mediated, disease as well. And so there's some thoughts that when you have endometriosis, you actually form antibodies to the normal lining of the uterus, which can also inhibit fertility. There's like a study out there that I thought was very, very interesting.
yeah, there's definitely there's a lot of information that's really looking, or a lot of studies that are really looking at that, just immune environment, just epigenetics in general, and inflammatory markers, and how that impacts fertility and just the environment of the endometrial cavity. So, and a lot of that has to do with endometriosis and adenomyosis too, which we'll talk about a little bit later.
All right, I'm just going to take a brief pause. I don't know if anyone has any questions related to anything that we have been talking about, some of the basics. before we dive into Michelle's story. We got a quiet group today.
I had just a little question. Could I ask?
Please.
Yeah. Just because of what you said, like about the endometriosis possibly changing the environment, like, are there studies showing that it might be changing the environment to then cause fibroid growth as well? Or I don't know if that's been studied or not.
Well, thank you for that question. I know I didn't see anything with the research. Dr. Jiggets or Dr. Wolf or Michelle, I've heard from folks.
I also have not seen that specific research either. Definitely endometriosis, fibroids, a lot of research on it. Endometriosis, a little bit limited. I haven't, personally seen it.
It's a great question though, and something we can pass on.
I think that's a great question too. There's like I said, there's a lot of studies looking at genetic markers and things like that between the two conditions. But I scoured a bit of the research. I'm sure if you look hard enough there, people are looking into everything because again, nobody's certain, about the actual connection. There's been more studies kind of like I'll have to look through my notes and maybe get back to it later in the thing, but there's, a study, I think it was out of Japan nurses study, and they had a large cohort of women and have followed them prospectively over 13 years to try to just understand more of the relationship between, endometriosis and fibroids, but I don't want to misspeak, but there are studies ongoing, but that specific change in the endometrium, I'm uncertain of.
Thank you for the question though, for sure. Michelle, what happens when you have both?
Yeah, thank you. But yeah, thanks, Tanya, and thanks, Dr. Wolf, for having me, and thanks, Dr. Jiggets, for giving an overview, because as you're explaining, I was like, yeah, that's exactly. And you really don't know after the fact. I just have to be really honest with you. When I say after the fact, I mean after having surgeries. So, but I'll get to that. So I think for me personally, I had very painful period when I was a teenager. So I started realizing that I couldn't, handle, or I couldn't sleep through a period unless I take painkillers when I was a teenager. And I also didn't realize I was bleeding heavily because they don't teach you that in school or anywhere until I was, trying on a tampon. And I remember I was in college and I was like, it was a super tampon. I bled through it in 20 minutes. I didn't know that was not normal until when I graduated from school, I finally had health insurance. So I went to see my first OBGYN, and then they had my first transvaginal ultrasound. And then they're like, something is weird. And so they're like, looks like there's something, you should go to MRI. And then after that, that's when they saw fibroids and also endometriomas. And just like what Dr. Wolf and Dr. Jacobs mentioned, you really they cannot officially diagnose you with endometriosis unless you have a surgery. So the only thing that my gynecologist recommended, and I saw several of them, only one recommended removal of fibroids, and nobody said anything about endometriosis. They only said just continue taking birth control. That's the only thing you can do. And so what happened was, fast forward, and the 10 years research is very interesting because it took me 15 years to get to the non-cyclical pain that Dr. Jagges was mentioning, where I was really having a lot of pain. I honestly, like, TMI, I couldn't even take a subway. So I live in New York. I could not take a subway from Brooklyn to the Manhattan without bleeding on the platform. I couldn't, if I take, 6 Advils, I could not even, like, I would just be on the floor. I wouldn't be able to, like, stand up to even make myself a sandwich, And it get to the non-cyclical pain because I started having pain outside of my periods and I couldn't understand why. And so finally I saw another gynecologist and they're like, okay, you have like 30 fibroids, you need to do something. And so at that point, I was like, well, I heard earlier that I also had endometriosis. Did you see anything? So that doctor, it's more like a fibroid specialist and not, or OBGYN, but not an endometriosis specialist. So that's like a differentiation that I didn't know. But so none of the doctors, and I, after hearing that diagnosis, I had 30 fibroids, I need to do something. They didn't really, none of them really said anything about endometriosis. They just said, just focus on your fibroids, and the best thing you can do is open myomectomy to get them out. And I did the open myomectomy. It helped with the bleeding so much, like it helped 50%, I would say. Before I would go through the overnight pads like every hour, overnight pad and a tampon together every hour. Now I can go on a few hours, right? So I know I'm a little bit TMI, but I want to just graphically explain. But then the pain was still there. And I remember when I was doing the open myomectomy, I asked the doctor, my surgeon, she's wonderful. And I was like, if you see endometriosis, can you also help with it? And she said, of course, but unfortunately I didn't know until up, and she kind of warned me earlier that, it's harder to see. And I'm sorry, Dr. Jaggers, you probably could correct me on this. It's harder to see endometriosis if you're doing an open surgery versus it's easier to see endometriosis if you're doing laparoscopic surgery. Unfortunately, I had to do open myomectomy because of the number of fibroids. She wanted me this ahead of time, so she went in, took care of all the fibroids, or half of the fibroids, because she couldn't cut too many out, because it would just, my uterus would just be destroyed. So what happened was I had to seek another specialist, an endometriosis specialist who could, be better diagnosed the endometriosis and, for surgery. So, and the whole diagnosis was interesting because it was like a special MRI, just to be like kind of graphic, like there's a gel that you have to inject inside for you to see better where the endometriosis is. So they saw that it's they saw that it's on my bowel, my uterus is stuck, my ovary was stuck. So they also had to do like a transvaginal ultrasound where they kind of go in, kind of move around and see if my ovary will be movable, and how my uterus is stuck, whatever. So basically, it was only after all this that I went in again for another surgery that is for endometriosis, and that was they did 5 incisions, 8 millimeter each, and then to get rid of all the adhesions and everything. So basically this is what happened. If you have fibroids, you have at least for me, you have very heavy bleeding, you have endometriosis, you have very heavy pain, and I would say definitely the only way to find the right doctor is a lot of times word of mouth. I found mine on a Facebook group. So yeah, it's an interesting journey. But it's not, I would say for fibroids, it was easier because the result was very immediate. Bleeding was dramatically decreased. For endometriosis, for me personally, I would say the surgery was maybe 20-30% helpful. It's harder, I think, to get rid of everything completely. But that was my story. Oh, sorry,
Before we
Tanya.
go on, I thank you so much, Michelle, for sharing your story. And just so you know, and Dr. Wolf and I always say there's no such thing as too much TMI. This is part of what we want to bust in terms of, because us talking about it is going to help with figuring out new ways, doing the research, all of that stuff. I did want to, you did have a bullet point there that I think is absolutely really critical to understand. You were able to find an endometriosis specialist, but on the other side of things, not only is it helpful to find a specialist or someone who has, knowledge and is paying attention to the research and the studies, but there are a lot of practitioners that don't have that awareness. And we hope to help change that too, but of the impact and some of these specifics around the symptoms, et cetera. So I do want to, because I know you sent, and we can send this out, or I'll put it in the notes on YouTube, but the link to the article that you talked about where, patients are not feeling comfortable because they do believe that there's not the awareness that they would want to have, and this sort of trust that they have that the doctors really understand endometriosis. And as someone who I had a good friend who had it, and she said she suffered for like 30 years before she was diagnosed because she's it's a slightly older generation, but then her niece is having the same symptoms she had and still not getting the diagnosis. So I understand, we all understand that it's not as visible. Surgery is the only way to sort of completely diagnose it. However, no one is even talking to her about it. They're just saying, like you said, oh, you just have painful, take some more Advil, use another pad or tampon, and that's not acceptable. Dr. Jiggets, Dr. Wolf, you want to add anything before we move on? Well, now that we know all this, if you get a good healthcare provider, and maybe you want to mention how to, sort of confirm that, the OBGYN that you're seeing is, at least well-versed enough. So Dr. Jiggets.
Yeah, thank you so much, Michelle. I mean, that was, it's great to hear, from a patient perspective, just kind of, some of the things you go through. But as a provider, it also kind of, breaks my heart when, my patients tell me, it took them 10 years and, you're the third provider that they're seeing. And, I don't want people to have that experience, but with endometriosis, a lot of times it's a lot of frustration. But so kind of piggybacking off of a little bit of what Michelle said. So the most important thing is really going to be the history. It's going to be you explaining what your symptoms are. From a provider standpoint, our responsibility is to ask. It's a lot of, different barriers, which we kind of mentioned already. Sometimes you have a time restraint. Sometimes, we're in a situation where maybe the physician is not even asking you these questions. Maybe it's the medical assistant. Maybe you're filling it out on a pre survey before your visit, right? So for me, I feel like it's important for me to specifically ask my patients about their symptoms. So I like to know about your bleeding. People say, oh, my bleeding is normal, it's regular. How many days are you bleeding? How long does it take you to go through a pad on your heaviest day? If you're going through a pad in an hour, completely saturated with blood, for me, that triggers me to say, what, has anybody ever talked to you about your bleeding? That you're bleeding, a lot. I would recommend that we do a workup for it and then kind of go from there, right? Another thing is if you're not able to go to work, you're not able to go to school, whether it's because of your bleeding or because of your pain, for me, that's another trigger for, this is something we should really work up. You shouldn't be, completely debilitated to the point that you can't function from either bleeding or from pain. So those things are important for me. And the other thing from a patient perspective is, if your physician is not asking you these questions, volunteer it. I can't go to work. I can't go to school. Sometimes I feel like, everybody has their own personality, but sometimes people don't know what's normal. Some people, have a great ability to just push through things, but, we want to know if you're, suffering for sure. The other part is, finding a provider who takes interest, who has the expertise, and who is really, interest is probably one of the biggest parts, I feel like, from a patient perspective that maybe you would be able to see in the office. So from a physician standpoint, as an OBGYN, it's a very broad field. We all love obstetrics. We love delivering babies, right? That's a significant part of our training. We all love GYN, significant part of our training. 70 to 80% of women will have fibroids. We all love fibroids. Endometriosis is hard to love. It is notoriously hard. It's hard for our patients. It's hard for us as general OBGYNs as well. So this is where, you want to get with a physician who has significant interest in endometriosis. So, when I go to my conferences and we go to GYN conferences, we're talking about endometriosis and they're talking about all the research and all the surgeries. I mean, we're all super excited about it. We're in a room full of people who this is what we really like to do. And for a lot of general GYNs, endometriosis is not something that everybody likes to do, specifically because it's hard for the patients. It's hard for us to diagnose it. It's not routinely seen on an ultrasound, not routinely seen even on MRI sometimes. Sometimes you end up with, surprise endometriosis during, some of your surgeries, and it can, lead to a lot of adhesions in the pelvis that brings in the bowel and it brings in the colon. And, I'm not a colon surgeon, so, sometimes that's hard to navigate. So what I would say for patients is you want to find a provider who's interested in endometriosis, who's interested in pelvic pain, right? If you're talking about it, they're asking you more questions about it. It's a back and forth conversation, right? Everyone's credentials are online. So if people have done, extra training specifically, in GYN, for the most part, especially minimally invasive surgery, usually these are people who like or who are okay with endometriosis, right? So kind of like Michelle said, when you're doing open surgery, it's hard to see endometriosis. It's detailed surgery. It's fine movements. It's zooming in. And that's what you can do with laparoscopic and robotic surgery. Also, with endometriosis, you want to have a team approach, right? You want to have a GYN. Sometimes you need a urologist. Sometimes you need a colorectal surgeon. So a lot of times you'll find these teams in large hospital systems, right? So this is not a surgery if you're concerned about endometriosis that you're going to do in outpatient, small, hospital that doesn't have, a urologist, a colorectal surgeon who are all in-house, right? I think those are probably kind of my biggest points, but absolutely, if you're concerned, a lot of times you have to advocate for yourself, really stressing the symptoms that you have. And then sometimes asking for an ultrasound for sure. You can definitely do that. I'm concerned to have fibroids. I heard that maybe an ultrasound would be good to find that, and just being honest about, what you're looking for, if that makes sense. Mhm.
So I was going to ask you, what about baby endometriosis, adenomyosis?
So
I'm calling it baby.
adenomyosis is so underrated. It really is. So adenomyosis, basically you have ectopic endometrial, cells or tissue that's inside the muscle of the uterus. So this can be very painful. And also you can have a lot of heavy bleeding. So I feel like a lot of times, patients may have fibroids and then, so people they may have fibroids and sometimes the symptoms are similar to having really bad fibroids. So with an ultrasound, you're absolutely going to find the fibroids. When you have fibroids and you have adenomyosis, it gets harder to see the adenomyosis when you have fibroids on an ultrasound, for sure. So then the next step, usually is an MRI, and typically on an MRI, you should be able to see the adenomyosis. But, how many people get to the point where you're going to get an MRI? Probably, not a lot of people. People kind of usually stop at fibroids and that's it. But, adenomyosis, it can make the uterus very large and it can have a lot of implications for fertility in the future. So, a lot of miscarriage with adenomyosis if it's diffuse, right? Sometimes people have focal, so just one area is affected, and that's okay. When you end up with diffuse, sometimes it can make it very difficult to keep a pregnancy, early on. So really just kind of advocating, being very honest about your symptoms, asking sometimes for an ultrasound, and just looking for someone who's interested in the topic, what you think you have and with your pelvic pain for sure.
All right. Any other comments? We're gonna, I forgot about this. We're gonna run straight to, because I do want people to be able to share and ask questions. So I'm actually gonna stop sharing for a moment. Let's see, I'm just looking in the chat. Yvette, actually, I'm gonna do what I said I was gonna do. I'm gonna pause the recording.
So it's not a medical term, so I'm not super sure what that means. I can guess, but if anyone else definitely knows what that means, I will sit back and listen.
I mean, I could even speak
Okay.
to it, like from a patient perspective, like it's very common to have a lot of bloating and discomfort. And for an endometrial, I had both. And so I think the fibroids also would enlarge, as well as the endometriosis caused bloating and it was the latter half of my cycle leading up to my period. Generally in the endo community, that's kind of what I hear endobelly meaning. Like it's more about bloating, gas. I myself have particular food sensitivities to gluten. Other people have other ones that also are worse with the symptoms. So that's like a patient perspective. That's just like my take on endobelly. I don't know if the person asking had anything else specific or anybody else wants to speak to it.
Well, thank you for sharing that, because I think that, I mean, Dr. Wolf was talking about some of the research around kind of this immune mediated sort of capability that's happening. And so I think, when you talk about things like gluten sensitivity and other things like that, that starts to sort of dovetail with that, so that you're experiencing the gas and the bloating, et cetera.
So another thing to add to that is absolutely it's an inflammatory process. So, if you're having bloating, that makes sense. Another very common conditions that are associated with endometriosis are irritable bowel syndrome, right? So having a lot of, different sensitivities, different factors that can kind of flare up bowel symptoms, and then also the bladder as well. So what we see is interstitial cystitis. So also kind of the same thing. So different irritants that can increase kind of the inflammation and irritation of the bladder. So once again, we always need more studies to really figure out the connection between these things, but it's very common with patients who have endometriosis. They may also have bowel symptoms specifically related to food, usually, end up being diagnosed with irritable bowel syndrome, and then also with the bladder as well. So. Yeah, so the question was about progesterone supplementation or just hormonal contraception, contraceptive options in terms of any benefit with fibroids. So there's definitely some studies that progesterone only medications can have a positive impact on fibroids, if that makes sense. So it can help slow some of the growth that we see with fibroids. With combined hormonal contraceptive, we're not really seeing that difference. But what you'll see is that sometimes, if we're trying to manage the bleeding associated with fibroids, sometimes people will, kind of recommend combined hormonal contraception. When you add the estrogen component to progesterone, sometimes it can help stabilize bleeding a little bit better. But in general, when it comes to bleeding, combined hormonal contraception or even progesterone, it really may not be super effective for bleeding specifically. But if you're looking at, preventing fibroid growth, studies do show that progesterone only can help to slow growth. Absolutely. And another thing is that absolutely, if you remove fibroids, they can always come back. But some studies show that if you have the fewer fibroids you have, some patients have one fibroid. If you have one fibroid that's very large, you remove that one fibroid, the chances of it coming back is actually a lot lower, than patients who have several fibroids, if that makes sense.
And then two, there's some newer medications out there that came out in like 2020, like Myfembree. I think Orion also, like, I know for sure Myfembree just got the indication, but these are, and Dr. Jacobs can probably correct me, like I'm an interventionalist who treats a lot of but I work very closely with my gynecologist, but Yeah, they're basically a gonadotropin releasing hormone antagonists with feedback of estrogen and progesterone. So they originally got and there's two on the market. Orion and Myfembry are kind of the brand names that you'll see. And I know Myfembry just got their indication also for treatment of endometriosis. So they can treat the symptoms of the heavy menstrual bleeding seen with uterine fibroids. And there's a significant reduction in the heavy bleeding to even no periods at all. And then they've also studies have shown that there's a significant improvement in endometriosis related pain. One of the slight downsides is right now you can only be on it for 2 years because there is a slight decrease in your bone mineral density, but hopefully over time, just knowing, learning a little bit more about these medications, that hopefully with studies that bone loss, at least it sounds like when compared to hysterectomy actually results in more bone loss. But that's something to talk, and I'll let Dr. Jiggetts take it from there. But that's my knowledge on that. But that's new and kind of an exciting thing, particularly if you have those two conditions or even potentially recurrence, I think.
Yeah, so definitely the GnRH antagonists, they're definitely exciting medications that kind of started off with the use for endometriosis, but now definitely in the world of fibroid bleeding management more so than bulk symptoms or basic the size of your fibroids. But absolutely, definitely can help your endometriosis pain and your fibroids as well. Basically what it's doing is kind of tricking your body into thinking it's maybe in menopause without giving you all the symptoms of menopause. And then they give you back some add back hormones. So people tolerate it usually pretty well, but definitely one of the newer medications that we're definitely seeing a lot of use for. But that 2-year restriction is definitely a little bit limiting, for some of our patients. But I know Myfembry is working on getting extended use because they do give the add back hormones. Whereas, kind of when we started out with these medications, they weren't giving add back hormones. So that's really where that bone mineral density decrease, where we saw that. But hopefully over time that will be eliminated.
All right. Well, we're gonna, if there are no other questions, and please feel free to jump in there. You guys can put it in the chat, as we've always said. I did want to just allude to these really quickly. When we did our survey, this is one of the reasons why we really wanted to start doing these things, is because it clearly is sort of a lack of connection of the symptoms with some of the conditions that we're talking about, right? So, if 50% of our respondents, and we had, close to 1,000 respondents that were unfamiliar with fibroids as a term. We asked, do you know what fibroids are? And, it was either no or sort of. They reported some sort of pain, pelvic, back, leg pain. 46% also reported symptoms of frequent urination. So again, don't even know that fibroids could be something that could be, the cause of this. And so maybe also don't, follow up with their healthcare provider. And then what we did, our number is sort of 14% of the respondents diagnosed with fibroids reported also being diagnosed with infertility. So again, we did not do the cross-reference yet as to, because there were 12% of our folks with fibroids were reported also being diagnosed with endometriosis. So didn't look at were all of those 12% or most of those 12% also kind of the folks that were diagnosed with infertility. That hasn't yet been, we haven't sort of conjoined that analysis. But the idea is, again, just really being aware of the fact that there may be, there can be many causes, but this is something to, as Dr. Jiggetts said, speak with someone who will be willing to talk to you about it. And I want to acknowledge the person who, and I don't remember if it was Meg, or that it is difficult. I do feel the providers want to spend more time with you. And unfortunately, I think that, Dr. Wolf, I know, always talks about this in her practices. It feels almost constraining in terms of insurance. And so that's a whole separate thing that we hope to be able to bust. We got to change the industry for that. And this is something I kind of want to say last but not least, because I do want to share that, I mentioned this at the beginning, and I think this comes full circle, is that, we're not necessarily represented as women in research, but then when you go deeper than that into, Black and Hispanic women, Asian women, et cetera, and then on top of that, you overlay kind of the bias that exists, right? When you talk about people who have been diagnosed and not dismissed, which does happen to women. So it's even more than, as Dr. Jacobs was saying, someone who isn't versed in endometriosis, but someone who actually is saying your pain is probably in your head. As Michelle said, take another couple of Advil. So when you look at, there was one review that showed that compared to white women, Black and Hispanic women were less likely to be diagnosed with endometriosis, while Asian women were more likely to have this diagnosis. The key thing that they also concluded was that it really, really, really is important to kind of caveat that with the fact that there are methodological flaws, and some of them are actually related to the bias that exists in looking at, there are also studies that show that there are many people leaving medical school thinking Black women tolerate pain more so than, other white, Hispanic, Asian. And so some of those things kind of, I think, confound and cause the flaws and the bias that we see. So it's again, the other point that was made here was even if it is the case, what's the relevance of this particular information in providing good patient care, right? Because we had from our survey, there was one statement that someone said that her doctor said she had sort of she was an exceptional case because she was a white woman with fibroids. So again, that was a stereotype that was there because, we still have the statistic that 70% of, white women, included by the age of 50, will have at least one small fibroid, right? So again, when we look at some of that stuff, I did want to mention that because you may be wondering that, and I know we've talked about that generally with the White Dress Project, that there are disparities where Black women seem to have a higher prevalence. So I think the number for Black women is somewhere around an estimated 80% compared to 70% maybe for others. And that may be the case, and that they also potentially suffer from more and more intense symptoms. But again, the idea is that doesn't mean that others don't. And whatever it is, the conversations need to be had with the healthcare provider, and they need to be invested in finding out whatever it is. Because again, these research studies don't include everyone, and your experience is going to be unique. As Dr. Wolf says, and I did coin this phrase from her, is that, your experience, you are a snowflake. So everything about, the little curves and the little sort of design that makes up who you are, both, sort of biologically as well as what's going on in your body is unique. And your healthcare provider should look at you as such and not just kind of lump you in. So we've given you all the symptoms. And so these are, if your doctor doesn't ask, then you can say, hey, I'm experiencing some, frequency in urination urge. I'm experiencing all the things we've talked about. You can go back and look and sort of see where you are. So be aware of your symptoms, but also be aware of bias. The December What the F was on Am I Bleeding Too Much? So you'll get a little bit more education on that. February was on painful sex and dyspareunia. So if you want to check out some other dive deep into heavy bleeding or painful sex, that's out there. The sex one was pretty spicy, if we must say so ourselves. Continue to educate yourself and others. Come to these every month, yes. And make it each one teach one, which is you go out and tell someone and they'll probably tell someone, and we can spread the word. If you feel comfortable, like me and Michelle, you can be TMI and tell them all about what you've gone through. And consider lifestyle options, because I talked about adverse childhood experiences and stress. And when we think about stress, there are many, many things that we can do to reduce our stress that fall into that lifestyle option. So not only what are you exposed to in the environment, but also what are you eating and how are you moving, sedentary lifestyle. And then for the May What the F, we're actually going to focus on studies and research that has suggested that certain things that you can do to at least be proactive in terms of keeping your snowflake as healthy as possible. So with that, we did want to put out there, we found this, we are not affiliated with them, But there is a research project opportunity, the Women's Healthcare Research. So again, that's entirely up to you. So again, we're not sponsored by them. We're not affiliated with them. We will be looking to them to understand their results when they come out. But they are currently enrolling volunteers. I talked about participation. It's absolutely critical. So that's, and they got a little compensation there. So April, we're going to be talking about fertility. So we hope to see you there. July, woo, 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 the Empowerment Experience, our second annual, July 14th through the 16th in DC. So if you're anywhere near there, there will be lots of sessions like this, lots of experiences where you'll be getting some of hopefully the information about lifestyle options as well as other things, and you'll get to see what the research folks have going on now. So I'm gonna breathe. Is there anyone want to say anything else before we close it out? Let me just check the chat. Yay. Okay. Well, I'm glad that everyone enjoyed it. Thank you for joining. Sorry about the difficulty. We will fix that. Everyone is very grateful both to Michelle for sharing her story and Dr. Jiggets for contributing your, I like to say specialist, because I always say you guys are the best experts. You're the experts at your own body. So it's great to have folks who work with this day in and day out, because they can provide you with information that you can synthesize and use. So thank you, thank you, thank you for joining. Dr. Jiggets, Michelle, thank you, thank you. And Michelle's app will be coming out if someone does think that they want to track their symptoms, etc. So you can sign up for the beta, I think, yes, on New Moon Health.
Yes, and also I have a directory out there, and I'm trying to crowdsource, because like what we mentioned is, you know, a lot of time it's kind of word of mouth. Would love to crowdsource a directory where it's really from patients' recommendations, people who have gone through the experience, who have looked for multiple doctors and finally found that one that, you know, who listened to them, like Dr. Jackets mentioned, and, you know, provide a good treatment. So if you go to the website, there is a Google form. Sorry, it's very manual right now. There is a Google form for you to submit a recommendation if you really love your doctors. So
do you want to put that in the chat really quickly?
Oh, sure. Yes, sorry.
No problem. Thank you. And Michelle and we are talking about opportunities to collaborate, because we obviously have a lot of great doctors we work with, like Dr. Jiggets. Dr. Wolf is in-house, so that's automatic. So, you know, that's one of the most frequent questions that we get is, how do I find a doctor that will be understanding, sympathetic, compassionate? So compassionate care is not a dime a dozen. It is definitely exceptional. So we want to thank all of the exceptional folks on the panel and all of the exceptional folks that were in attendance, that persevered to get through the Zoom and made it here. So thank you, thank you, thank you. We went a little bit, not quite over, because we started a little later, but thank you for hanging in there with us, and thank you for attending. Have a good night, everyone.
Thank you.